Well, good afternoon. Thank you all for coming. Always good to see our panelists meet each other. I like that. Welcome. I'm Neil Chase. I'm the CEO here at CalMatters. Appreciate everybody being here for this conversation today, and especially to all of you for giving us the time to get ready for this and to do this and to come have this conversation. We cover California policy and politics. That touches a lot of things. When you see an issue that really touches individual people and the quality of life and the quality of healthcare in our communities, it's so important to have these kinds of conversations. We do the stories, we do the reporting, we try to share as much of this as we can, but there's something special about getting a conversation together in person with people who are involved, who understand the issue, who can go back and forth and help us understand it. And we describe this as live journalism, right? This is a chance to do the interviews that we do, but in person, in front of people, let you all talk about it with yourselves and with Kristen, have the audience join us in. We have a bunch of people here in the studio. We have a couple hundred people joining us online as well from all over California. So really happy to have everybody here. If you're not familiar with CalMatters, we're a nonprofit news organization covering California. We have 75 people on staff all over California. More than 50 of those are journalists. And we try to bring information about state government and state policy and state issues to people in the places where it matters, which is why we cover these issues all over California. So really thrilled to have this group here today to talk about this. We encourage you to share your questions, and when we get to the later part of this, about 15 minutes till the end, we'll take questions from the audience. And with that, I will turn it over to Kristen and let her get things started.
Thank you for that introduction, Neil. In the past 3 years, 29 hospitals in California have stopped labor and delivery services. It's a trend that has rapidly increased in California recently. This year alone, Adventist Health Simi Valley, Adventist Health Tulare, and Scripps Health Chula Vista have announced their intention to close their maternity wards. 3 weeks ago, Ridgecrest Regional Hospital delivered its last baby. And Madera Community Hospital, which recently found a new buyer, will reopen without a maternity ward, leaving that county's 160,000 residents with no choice but to go outside of the county to have a baby in a hospital. There are 12 counties in California without maternity wards, and the shuttering of these service lines has profound implications for access to prenatal and postpartum care, as well as on maternal and infant outcomes. So today, I am thrilled that we are joined by 4 expert panelists to talk about this very important issue. To my left is Dr. Robert Moore, Chief Medical Officer of Partnership Health Plan of California. Next to him is Peggy Wheeler, Vice President of Policy for the California Hospital Association. Kimberly Robinson, who is a community liaison and leader for Black Women for Wellness, and Paris Malouf-Bori, President of the California Nurse Midwives Association. So there are 3 things to kind of just draw a roadmap for everybody that I want to hit in this conversation. I want to talk about the why, how we got here. I want to talk about the impact on the community that these closures have. And then I also want to, since we have such wonderful experts here, pick their brains about creative solutions on how we move forward in thinking about maternity care. So let's lay some groundwork, and I'll start with the why. Peggy, I'll put you in the hot seat.
I love it.
The Hospital Association represents hospitals of all shapes and sizes across the state, and hospitals have had a very difficult time in the past few years. I know you hear from your membership all the time about, the things that they're struggling with right now, increased costs, labor shortages, things like that. Can you start to unpeel some of those layers of all of those myriad factors that impact decisions to close labor and delivery?
Thank you. And let me start by thanking you and CalMatters for bringing this issue for discussion today. He used the word special, and I think that when we talk about delivering babies, it becomes a very emotional conversation. Hospitals provide services in their community to mirror what is needed by their community. All of us in this room remember the name of the hospital where we were born, so it's something we're always tied to. So the decision to discontinue those services, and now it has many names. We call it consolidation, we call it suspension or pausing, and then outright closure, but these are very difficult decisions. And they're based on a number of factors. There isn't one reason why a hospital would make that decision. But it does seem that we are in a time where those reasons are coming together. They're colliding with each other. We can talk about maybe why that time is occurring now, but let me talk a little bit about what the reasons are. One of the reasons is that in California, we are experiencing right now a decline in the birth rate. California is, and that hasn't happened for 100 years in California. I was really surprised to learn that. But we are now 42nd in the number of states in terms of our birth rate. So overall, we're just seeing not as many babies being born. OB is one of those services that obviously for the specialized staff that you need to have available, for safety reasons and competency reasons, there does need to be a certain number of births occurring in facilities in order to keep up those skills. So that's one thing our hospital administrators worry about. The other is for some of our small and more remote facilities, most of whom I work with at the Hospital Association, they are having more and more difficult time recruiting and retaining. So not just recruiting, but retaining those specialized services. Many of our small and rural hospitals operate their OB units with family practice physicians because they can't get specialized board-certified OB doctors into their hospitals. And then it requires specialized nurses. The other thing, you all, I'm sure, know this, in order to provide OB services, you have to have them staffed 24 hours a day, 7 days a week. That requires shifts of specialized nurses, almost in a situation where you're waiting for the next patient to come in, and that can be hard to retain them for those reasons. The other thing has to do with
Expensive, too.
Yeah, and expensive. Other than the emergency department, the OB service is the highest cost center probably in most of these hospitals. And then finally, and I think we'll all touch on this and won't get disagreement, is if it's a high cost center and you don't get reimbursed for what it costs to provide the care, you are losing money. And many of these hospitals would continue to lose money if they could make it up someplace else in the hospital, but they have tried everything. They are moving things around, making different decisions, because this is the service intrinsically that they would like to keep in their communities. And it's an agonizing decision when they have to shut it down.
I'll also just interject and say, in the course of my reporting, talking to different hospital CEOs, there are some in smaller hospitals that have recently closed labor and delivery who told me that they had positions posted for labor and delivery nurses and doctors for more than a year, and not a single person applied. So it can very much be a challenge to recruit staff to those areas. Bob, Partnership Health Plan covers 24 counties in California. A lot of your counties are these more rural and remote areas. And you have really taken it upon yourself to do risk analyses, because in these areas, any one loss of a service line, whether it's maternity or anything else, like, it has a big impact on your patient population. What are some of the tipping points and trends that you've noticed that sort of precede these closures?
Yeah, so we have about 50 hospitals roughly in the 24 counties we serve north of Sacramento and north of the Bay Area. And of those, half stopped at one point or another doing OB services in either the distant past, and about eight or nine of them in the last 8 or 9 years. So what I did is I went to talk to those who closed more recently and found that there's never, as Peggy said, there's not one reason that they stopped doing OB. But I would say that the three broad categories I found were in the most rural areas, the tipping point often is the nursing staff, as Peggy mentioned. I think it is a combination of you have to staff 2 to 3 OB trained nurses 24/7. That's a lot of shifts, and if you have low volume, even if then it's expensive. But even if you have the dollars to do it, the hospitals that lost it, they just couldn't find nurses willing to work those shifts. They were too remote. So I think nursing for the most remote, that was the common factor for them. For the more suburban hospitals, it was different. It was probably the cost was more due to the physician costs. Could be the anesthesia coverage or the pediatric coverage, actually. Paradoxically, if you do have OBGYNs covering a low-volume hospital, then you have to hire pediatricians to sit around and wait for a baby that is born that may have some problem. That's very expensive as well. And some hospitals are willing to do that and are pouring money into doing that, and I really appreciate those that are doing that. But if you have the hospitals that do rely more on family physicians are able to have the family physician cover both the obstetrics as well as the peds, and that keeps the cost down as well. So that's and then when those hospitals are having those high costs for those individuals, often it's not a tipping point, but a key factor is they may have another hospital that's 30 minutes away that's in the same chain, and if they close one, they actually save money. Their cost structure at the remaining hospital is better. So we had 3 hospitals that closed where they had a part of their same organization within about 30, 40 minutes away. And so in the end, it was a corporate decision. It is costly, but they were a big chain. They could have afforded to keep it open, but in the end, they made the choice to close one of those 2 that are close to each other.
I want to follow up on that. I think that this will probably dig a little bit more into the finance question, but this has been, maternity ward closures has been an ongoing issue across the country for a very long time. California we've had closures over time, but it's happened, I think, slower than it has in other areas of the country until 2020. So I'm curious to get both of your takes on like what changed in 2020, and that might be there might be an obvious answer.
Want to do the obvious answer? So the obvious answer is probably COVID. COVID is an unplanned expense that we all experienced. We all experienced it differently, but at least for the hospitals that you go to, they were overrun initially by COVID. And at the same time, so you're asking hospitals, not asking, this is just what they do, they're getting an influx of very sick patients, but at the same time, we asked them to turn off the ways they make money because we did not know how the disease was being transpired between people. So no more surgeries, no more visits, no more anything. So you turned off the income and increased the revenue, increased the cost going out. And then, along the way, the federal government started to make some loans and grants to hospitals to help them with that. But you had to pick up traveling nurses. There were so many other expenses. And once you turned those on, there was no just turning them off. Those expenses still exist today. In fact, I had an earlier conversation with a CEO who was telling me that she's been able to bring down the number of traveling nurses, but she doesn't know that she'll ever stop using traveling nurses, and that is an expense center for our hospitals. So COVID is probably to blame.
I think so too. I think the only thing I'll add is that, hospitals, they have good years when they build up their reserves and they have bad years when they use their reserves. COVID caused a large number of hospitals to really have their reserves decimated. And if they're not in a larger chain that has options for spreading costs or financing, particularly the smaller hospitals, those are the ones that often will be they have to make the most difficult decisions.
There was a recent assembly committee, the Assembly Budget Subcommittee for Health, the longest name in the world, where there was some pretty moving testimony from hospitals about their current financial situations. And one of the questions that an Assembly member asked was, didn't you get billions of dollars of federal aid, and what happened to that money? And the interesting answer that, at least that I found interesting, that came out of that was that, yes, hospitals did get that aid. But as you mentioned, Peggy, the aid has stopped, but that doesn't necessarily mean that the inflated costs have gone down. And so this is kind of a long-winded way to reach back to another point you had, which is hospitals, do hospitals have a responsibility to swallow some of those costs on loss leaders, like maternity wards, or are they just in a position right now where they can't?
So I would characterize it this way, and let me make one comment about COVID. So the money that was made available, and not just to hospitals, but to restaurants and other small businesses to help keep them going when they had to turn off everything, stop seeing any of your clients coming in, that money was specifically targeted to be used for COVID expense. And so in the follow-up, there was an assessment done by each hospital of whether they were able to use that money for COVID expense, and if they didn't, they had to give it back. So our hospitals have been in that process of making that assessment. So it wasn't just billions of dollars that they were able to use for anything they wanted to shore them up, but they had to use it specifically for COVID expense. And there was disparity, and I know we're going to talk about equity and disparity. There was disparity even in how we treated COVID patients. So there was, that caused some disparity in how expenses were targeted. You used the word responsibility, Kristen. I will tell you that in my work, and I've been with the Hospital Association for 18 years, hospitals provide OB care not primarily because they feel responsible for it. They want to provide OB care. Especially, and I think, Bob, you can agree with this, especially in small and rural, because these aren't patients. These are neighbors and friends and people you see in the grocery store. They feel tied to the people in their communities. And so this is a service they really want to provide. And I know we're going to touch on some of the emotional decisions that go into this, but I would say that this is, I've used the word agonizing before, it truly is agonizing when they have to come to that decision to close that service, because it's babies. Everybody wants to be around the babies. So.
Yeah, thank you for that. I want to turn the conversation over to impact and also bring in our other panelists. To pick a specific example, Centinela Hospital in Los Angeles ended labor and delivery services in October following the death of April Valentine, who was a young African-American woman. The hospital has said that the reason for the closure was because of a pre-existing declining birth volume. For some added context, I think it's important to note that Centinela is in Inglewood, which is a 40% Black neighborhood and a 50% Hispanic and Latinx neighborhood. Kim, you were involved in the community work after that particular closure, talking to people on the ground, talking to locals about how that closure impacts them. And I'm curious to know if you can share, what you heard from the community.
Yes, thank you. So yes, we at Black Women for Wellness really rallied behind the families. I'll just go before the hospital closures of April Valentine and also Bridget Cromer. Those were two women a month apart who died after childbirth in the Los Angeles area. And so just speaking with the families and then also speaking with the communities, it was very disheartening to hear the lack of support that birthing people were experiencing. not only the lack of support, but also just the feeling of them not being listened to, not being heard. When they had health conditions that they were bringing to their providers, they were being dismissed. And historically, this has been the case for Black women, Black birthing people, and people of color. And so we wanted to uplift this because you have to get to the root cause of what's happening in order to be able to tackle the situation. And historically, I mean, it goes back to slavery time when Black women were used as experiments. Experimental treatments were done. And Black women are seen as can take a lot of pain and have thicker skin, and so we don't feel, or the perception is that we don't feel what we're saying. And so when you go to the historical aspect of it and understand what has been happening to Black women and Black birthing people and people of color historically, then it brings you to, okay, why is now we have a hospital closure after a death? And, we are being told one thing, but what we see in practice is something totally different. And so what folks are feeling is now that there's the maternity deserts that we are experiencing with the closure of hospitals, and also with the maternity deserts also bring a lack of access to providers in those areas, because you have to be able to deliver at a hospital. And if that hospital is no longer in your area, now you're being faced to travel. And so I understand that hospitals, when they're looking at, reasons for closing, and what I'm hearing is more of the financial aspect of it. We're leaving out the women and birthing people who are now having to experience not having a place to go to deliver the baby that we all want to see, And so it just, I can go on about this, but it just, I'm appreciative to have these conversations, and I think we need to have more of them, and we need to bring the hospitals administrators in these conversations, and as well as the folks that are being affected by this, to kind of hear, what your decision is doing outside of a financial aspect, but more so of an access aspect to those who are needing these services and now having to travel 2 hours to deliver your baby. And I would not want to be faced with having to have that be my.
Yeah, and I want to clarify something that you had brought up. When you say 2 hours, you mean in Los Angeles.
In
Like,
the
this is
Inglewood
not-
area. No, this is not rural.
This is traffic.
This is traffic. This is 14 miles can take you 2 hours, and if you're in labor, you know how, what that impact is. Yes.
And something else that you and I had talked about previously was sort of how this population of Black women, California does really well relative to the rest of the country when it comes to maternal and infant outcomes, but we still fail Black women. And something that we had talked about before was how this is a population that has some of the worst health outcomes across a variety, like a whole spectrum of health issues, and that when you lose a maternity ward or your local, ability to get prenatal care or deliver close to home, that's like another burden for that community. Can you talk about some of the impacts?
Yes, and I will say California and our health system has failed. Even yesterday, I learned of a mother who died postpartum from preeclampsia here in Sacramento, and she lived in Stockton. And so we're failing at a high number. We had, just in California, last year, 5 that I know of maternal deaths, post and pre and post delivery. So, You know, I just think of how can we stop failing? And when we were talking earlier, I think one of the ways to stop failing is to start listening and to start um, hearing what is happening in your area and not sugarcoating it, because the outcomes are not pretty for Black women and Black birthing people. Becoming pregnant should not be a death sentence. And that's what it's turning into every day when you turn on the news and you hear what's happening.
Yeah, and I should say, I believe, correct me if I'm wrong, I believe the actual statistic is Black women and birthing people are 4 to 6 times more likely to die from pregnancy-related cause.
Yes, and I work in Stockton, which is San Joaquin County, and San Joaquin County is one of the highest, we have the highest rate of infant mortality in the state. And so, yes, these conversations need to happen, and we need to figure out how to stop this.
Paris, you work as a midwife in a hospital that has recently had, and thank you for sharing that, Kim. It is really, tragic.
Yeah, and I don't want to bring the darring conversation, but it's important to have.
Very important. Kim, you work at a hospital as a midwife that has recently had, neighboring maternity wards close, and you've had to absorb that patient population. I'm curious what, like, your experience as a provider, what that impact has had.
Thanks. Kristen, if it's okay, before I answer, I want to just take a moment to hear and acknowledge what Kimberly shared. And I'm going to go back to, I'm president of the California Nurse Midwives Association, and we were getting nothing done for so long that we were trying to do advocacy-wise in this state until 5 years ago when we decided to stop advocating for midwifery and didn't run our own bills in the legislature anymore, and said, let's see what Black Women for Wellness is doing, because Black women in this state have the hardest time, and what if we followed the community leaders? And it has changed our entire paradigm and everything that we've done. Our successes and our effectiveness are completely because of this women's organization, and because instead of trying to decide what was best for people, and midwives in California, I'm not, but midwives are majority white by design. We stopped acting as white saviors thinking we could fix this, and instead looked to leaders in the Black communities and said, tell us what you want us to do. And we started to do that. We suddenly learned a lot about power, about the power of community, and about listening to Black women and doing what they say. So I want to call on anybody who's listening to this conversation today to talk to this woman and to listen to the Black community organizations and other people who are living in these underserved communities. Ask them what they need, and then do what they say, because they know nobody loves these babies more than these women. Nobody cares about these communities more than these families that live there. They know what they need. We need to listen to them and trust them and figure out how to get our act together to mobilize to do what we came here to do. Our why is you.
I appreciate that.
Mm-hmm.
I'll add to that too really quickly. The California Healthcare Foundation does a wonderful annual survey that shows that Black women are the most likely to want a midwife or doula, some of this alternative pregnancy care, and they are the least likely to access it. I put it in quotes.
Alternative, yeah. Midwifery was the first profession. I don't care what anybody says. So yeah, I work at Sutter Davis Hospital just over the Causeway, and I have the remarkable privilege of providing care to women and birthing people and families during their pregnancies, during their childbirths, during their postpartums, also just whatever reproductive health care they need that I can do, I get to do. And we had a loss of providers in Solano County, next door to Yolo County. And so we've been working really hard to absorb those patients, which is a privilege. You know, I am honored to care for anybody who trusts me with their care. But it's definitely been challenging because our volume at the hospital increased significantly, as you can imagine, which has called on us to completely reshift our model at the hospital. Typically, the midwife is first call for all patients, and the doctors can take call, like where the midwives are in the hospital 24/7, and the doctors have been able to take call from the clinic where they're seeing patients, or from home if it's the weekend or the middle of the night. And our volume is too high for that now, so we're trying to figure out how to afford to have 2 providers in-house 24/7, in addition to the pediatrician and anesthesia and all the other pieces that go to it. It's working, and it's not enough. We've been able to help staff the clinics there so that the people are able to, once again, get clinic care, outpatient, prenatal, postpartum, et cetera, care continuing in their own clinics to a large extent, and our physicians are supporting. So we've got midwives, nurse practitioners, physician assistants providing the outpatient care for the most part, and then our doctors are working really hard to rotate through those clinics so that things that have to be done by a doctor, it's not every day that there's access there, but it's being figured out, and we're working really hard to hire more obstetricians so that there are more doctors to staff those clinics and our hospital, which, as Peggy and Robert shared, is not an easy endeavor. One of the things that we haven't figured out yet is childbirth classes. I'm super proud of our hospital. We have at Sutter Davis free in-person childbirth classes. We have lactation services, free breastfeeding support group. We've got group prenatal care. We've got all of these wonderful pieces. Our goal is not just to get the mother through pregnancy safely and deliver the baby safely. Our goal is to help to create a family system, not to create it. The family is going to do it. Our goal is to help create a setting and provide resources so that this woman, this birthing person, their partner, their family can do what they want to do, which is to have a safe and health pregnancy, to get all the education and support that they need to bring their child into the world safely, and then get support via the healthcare part of the village to meet all of their goals. We don't have that yet in the neighboring county. We've been working on trying to figure out how, what can we do? Where can we get the funds? Where do we get the people to do the work? Do we have...
Oh, sorry, I don't mean to interrupt. I was just going to say, what I'm hearing is that when these closures happen, it's not in isolation.
It's
It
not.
creates stressors on other parts of the healthcare system.
And I know that traffic in Yolo and Solano County is not LA traffic, but it still is over an hour drive, well over an hour easily from the other side of the county. Some of those people, they're not going to make it, and they're choosing to go the other direction and see if they can get out to the Bay Area instead. So it's definitely a challenge.
I think this is a great point to turn the conversation to solutions. I want to make sure to get to all of you and talk about some of the ways that we can start. This is a complex issue, as you've all outlined, and I think it's probably going to take rethinking how we approach maternity care. Why don't we start with you, Bob?
Sure. Yeah, so thinking about this quite a bit, and we brought together some national experts to kind of help us think through this. There's a couple of no cost policy items. There's a couple of low cost, and then the big one, which of course is the financial one, which is very essential, especially for smaller hospitals, coming up with an alternative model instead of paying for each delivery the same amount, which doesn't work in a low volume setting, which has higher fixed costs per patient. There needs to be something different. But so I'll let you talk about the finance part. But for the no cost, the Plumas District Hospital 2 years ago closed their maternity ward. I should say they stopped delivering, and they really are trying to set up a birthing center up there, which they're willing to license, but they need to have a flexibility provided by by statute to allow something that they're calling a standby perinatal service. So it's similar. We have standby emergency services in small rural hospitals where there's not everyone has to be there when there's no patients to be seen in the emergency room. They can be nearby and come in when a patient arrives. Same idea with a standby perinatal service, and that'll help with that cost structure that we talked about. So we really support that, but at the end of the day, all the flexibilities that were needed are not quite enough. There needs to be some statutory change to allow that. So that's one that I just wanted to really advocate for.
You've talked to me before about how a lot of our hospital regulations have like a structural urbanism built in.
Yeah,
That
it's a
sounds like
term.
one of them.
Yeah, it's a term that was coined. It was an article in Health Affairs a few years ago. The idea is that we create policies, and the people writing the policies are usually from cities, and those policies are designed with the subconscious, intrinsic bias towards urban solutions, and they just don't work in rural areas. So just being aware of that can help flip the dialogue a little bit. So we talk about structural racism. There's structural urbanism as well. The second one would be to allow birthing centers to not require for Medi-Cal to be licensed. Right now, there's another, so anyone who's non-Medi-Cal can go to an accredited birthing center. There's many of them throughout the state, but if you happen to have Medi-Cal, that we're not allowed to contract with birthing centers that are accredited but not licensed, and the standard is a bit more difficult. It's similar to a hospital in many of the standards. That'd be a second sort of no cost. Just change the policy. The two medium cost ones are, I think that if you look at the hospitals at risk, and I've gone to the hospitals that deliver under 500 deliveries per year in our region and talked to them, and every one of them is different, but they all have interventions that I can start to do before they start having difficulties. And they vary quite a bit, but I think that it's a leadership approach, not a compliance approach. It can't be tell us that you're about to close, and then we're going to put you in front of a committee and make you feel uncomfortable. That's not going to change the situation. You need to figure out quietly, because once a hospital is thought to be at risk, women don't want to go there to deliver anymore, and doctors don't want to work there, nurses don't want to work there. So you need to be supportive in a quiet, sort of engagement sort of way. So that takes some resources, because some of those interventions require some resources. The other one is to, particularly for the nurses, to create a rural nursing education track. So right now, nursing school has become very, very specialized. You go to nursing school and you come out and you're not able to do anything in the hospitals. You have to do additional training to go in one area, to do OB or to do intensive care unit, to do ER. And in rural hospitals, they need generalists. They need nurses that can jump to the operating room, can go to see patients in the emergency room in another shift, and jump over to labor and delivery. If we have those kind of nurses, that would decrease the burden dramatically. So those are the four, plus the finance one, and I'll turn that over to Peggy.
So I will then add, with those brilliant ideas, and they are brilliant, we still need to cover the cost of providing the care. And so I don't think anyone would disagree that in order to provide the care, you need the money to provide the care. So the hard, easy one is to increase the Medi-Cal reimbursement rates so they're closer to covering the cost of care. I don't think Medi-Cal's ever going to be the one that covers the cost of care, but there's such disparity between what a commercial insurance company will pay for a birth and what Medi-Cal pays for that birth. So no disagreement, I hope, in the room that Medi-Cal could be a better payer. But creatively, perhaps for inner city or urban remote places, as well as for rural, the state could consider, and this again, hard to say in a budget year like we're having now, annual sustainability grants that prop up these OB units so that they have the ability to bring in those interventions that you're talking about. Nurse training so that they stay competent. I learned just this morning about Victoria. I don't know if anyone knows about Victoria, but Victoria is not just a mannequin that can be used to help nurses keep their competency, but really allow them when they're not in a delivery to be, working with this particular artificial intelligence kind of.
Is Victoria the name of the mannequin?
Victoria is the name of of somebody called it a doll. I refuse to call it that, but it's really a learning tool. But when I asked how much it was, it's about $80,000 to $100,000. So. Would that be an appropriate investment for the state of California to make in order to be able to increase and keep the competency of nurses that are in low delivery areas?
Go ahead, Kim.
So I think for one, thinking outside the box and maybe bringing back some of our older and wiser and true practices of, one, not seeing midwives as an alternative.
Entry to care.
Right. And, we hear that birthing people also want to start back having home deliveries. And so being able to support that as well. Doulas, bringing doulas into the fold, the mix, or we actually worked on legislation when we're talking about increasing Medi-Cal reimbursements to pay a doula, a living wage, for the services that they're providing. So I think just, looking at some of those, and then, just goes back also to listening to the person who is giving birth and, hearing what they say yeah, and also supporting the fathers in this because, we don't want to leave them out of the mix as well, which they are often. So, just looking at the whole family and creating that community that we used to have. It takes a village. It takes a village.
Oh my goodness, so many great ideas. I want to do a quick shout out to Martin Luther King Hospital in Los Angeles. So that hospital has a 96% Medi-Cal payer rate for their patients, and in Los Angeles.
Sorry, 96% of their patients are Medi-Cal patients.
Yes, thank you. 96% of their patients are on Medi-Cal, and very high rate of Black birth. And contrary to what statistics might deem destiny, they have one of the lowest cesarean section rates in California. It used to be our hospital, Sutter Davis, and we have a very worthy rival in MLK. And one thing that both of our hospitals have in common is midwives are entry to care when patients come in. At Sutter Davis, our patients have the option for a doctor. Most choose midwifery care. Some risk out of midwifery care. At MLK, the midwives see everybody, and if the patients need a doctor, they get a doctor. Midwifery care is very high value, and when we live in a state that simply does not have enough obstetricians, not enough to go around, I think it's time for us to utilize the midwifery workforce to help distribute care equitably. And MLK is an example of not just reducing racism-based disparities, but to a significant extent, eliminating it. And I think we could do that everywhere.
I'll just say, I was at MLK on Friday, visiting their maternity ward, and it is quite beautiful to see the way that they provide that care, midwife-led care.
Yeah.
But there are also challenges with the midwifery workforce. I don't know if you want to touch on that.
Yeah, sure. Yeah. So we used to have several midwifery programs in California, and we are currently down to 2. Cal State Fullerton and UC San Francisco are the last remaining midwifery programs in operation due to funding and other reasons. UCSF's program right now is in peril. midwifery requires a master's degree by law, by board certification, et cetera. So certified nurse midwives have to be master's prepared. We're registered nurses first. We've got our RN license, and then we go back to grad school. The UC system has determined that all of their advanced practice nurses through the School of Nursing must now graduate with a doctorate. They're no longer offering a master's program, and they require that their faculty all be doctorate prepared, and we don't have that in California. There are 1,419 nurse midwives right now in the state, which is a far smaller number than nurse practitioners, because we're very specialized. We just provide reproductive health care, whereas nurse practitioners are on all kinds of specialties. So finding nurse practitioners with doctorates to teach in those programs is quite simple, but finding doctorate prepared midwives in order to keep the program functioning is quite impossible. So in effect, the program is shutting down until they have appropriate faculty. We've had program after program shut down in California. UC San Diego shut down several years ago, as an example. UCLA shut its program. So this is going to take us down to one program left in the state, which is able to graduate about 12 midwives a year, which is not enough given that our workforce is already inadequate. And CNMA is in doing all that we can to help advocate for a pause in this and hopefully a stopping of this, because it's not necessary. Our outcomes as midwives are really good. Midwifery as it is enough. We just need more of us. We don't need to make it harder to become a midwife, and we certainly don't need to make it harder for people who can't afford a doctorate. You know, it's already a master's degree, and we're not lacking in outcomes. So this is just going to make it harder to get into the school, harder for the school to continue running, and continue to whiten the midwifery workforce when we are trying to re-diversify right now.
And I think, as everyone has outlined before, you know, there's a shortage of maternity care providers at all levels, and so this is another example of it getting harder to sort of fill those gaps.
Yeah, I would also say that a lot of nurse midwives in California aren't working as midwives. Many hospitals have barriers to midwifery practice, and so midwives often end up working just in the clinic, essentially as nurse practitioners, or revert back to working as RNs in labor and delivery. And so that's something that our hospitals could do differently to better allow midwives to work to the full scope of their practice, their training, so that we could better serve people. I would also like to point out a couple of things. One exciting thing that Robert was sharing was about the Plumas model. The midwife that they have running that, Lori Link, is a colleague of mine. She serves on the California Nurse Midwives Association Board of Directors, and we're so excited. So this is a really, really critical model to consider in terms of solutions. In having hospitals, critical access hospitals that don't have the staff to run a labor and delivery unit, either collaborating with or owning a freestanding birth center run by a midwife and an RN. And those midwives can provide care to low-risk people who qualify, but the law requires that they be within 30 minutes of a hospital, right? And so having that critical access hospital be available for emergency services like a C-section, which doesn't require having a hospital in-house 24/7. It requires having a doctor available who can perform that surgery. And another part of the Plumas model is having community clinics that can provide care to people who have higher risk in collaboration or consultation with physicians who don't have to be on site 24/7, just like we've done in Solano County. When they closed down, we said, okay, how can we get advanced practice clinicians, midwives, nurse practitioners, physician assistants out there to run the clinic? And we've got protocols that we can follow that we've developed in consultation with our obstetrician or OB family practice doctor, and we can call and consult when we need to. They don't actually have to physically see every patient when there aren't enough of them to go around. And further, they can do risk assessment throughout the pregnancy and throughout the postpartum period and connect them with appropriate birthing facilities. So even if they are at a distance of 2 hours from the nearest hospital that can accommodate their birth safely, they're not having to go 2 hours for every single prenatal appointment, which is every 4 weeks, and then every 2 weeks, and then every week, and sometimes multiple visits a week, depending on the acuity of the patient. So there are ways that we can stretch this if we decide that the way that we've been doing it since the end of the Civil War might be due for a refresh. If we decide to bring back midwifery, if we decide to collaborate with the nurse practitioners and the PAs and get really creative and not say, this is the only way to do it. It has to be a hospital. It has to be a doctor. You know, I think we are short-staffed enough at this point that it has to be all of us. We all have to decide to stop fighting against each other and open up and come together and say, okay, here's the situation. Let's synchronize and synergize and get all of us out there.
And I thank you for that, Paris. And I will say that we were very proud to work with Plumas and Dr. Moore to help them submit the grants that they needed to try to get money to support. Nothing can be done without the resources
Totally.
to support even brand new models. But it often takes running against that windmill many times before you can get something like that funded. I want to tell you, we are committed to
they get it
continuing to do that
approved?
work. They did, yeah, they did not. Yeah. Yeah, but the good news, and there's always good news, is that they did fund others. So we need to watch what's happening in the rest of the country, create the innovation labs here in California so that we can continue to promote the work, even if you don't get it the first time. You got to keep trying.
Another piece to that, I think,
I want to
too.
make sure, I'm so sorry. I do want to make sure we're running a little bit low on time, that we take a couple audience questions. So do you want to finish that thought real quick?
Oh, I was going to say, with supporting the Plumas model, I know Lori Link, the midwife there at Sutter Davis, we've got her now doing per diem so she can keep up her skills. And we're trying to figure out how we can support the family practice OB doc there in maintaining their skills. And I imagine that we'll be able to do the same thing in the future with nursing if we just get our heads together.
All right. Evelyn is going to come around with a mic.
Hi, my name is Malu, and I am a registered dietitian. And Kimberly and I were talking during in the beginning. So I do work with gestational diabetes and hypertension and preeclampsia and all that. But I don't get a lot of referrals yet, and I'm just wondering what effort is being made to help with just improving maternal outcomes. So their weight is in check, their blood pressures, all that stuff that we can work on, tons of things before it gets to the point where they're, in distress.
I know that in best practices, those services are all included as wraparound. In our practice, we have a dietitian who all of our patients with diabetes see. And they work really closely with our nurses as well for monitoring. But I also know that this isn't the case everywhere. Comprehensive perinatal services programs are supposed to include all of these things. But I think sometimes they refer out, and I think that sometimes in the referral process, things might get lost. But best practices is to have all of these services in-house. I'm not sure what the state is looking at in terms of helping to make that possible.
Yeah, so there was a state auditor report, came out middle of February. The state auditor looked at the California Department of Public Health and the Department of Healthcare Services and their oversight of CDPH, and they had a number of findings and recommendations. The bottom line is that they've decided to define the CPSP program as a program that was only ever intended for fee-for-service Medi-Cal, not for Medi-Cal managed care, which is where most pregnant women with Medi-Cal are currently receiving services. And by that definition, the CPSP is basically being phased out. They've taken the oversight from the counties to the CDPH, and even that, the oversight is pretty minimal. I look at it as a blessing because they're saying, health plans, you figure it out. So partnership is really leaning in to take those core services of a California Perinatal Services Program, which is nutrition, case management, mental health, and education, childbirth education, and other education, and to strengthen them with oversight directly from Medi-Cal managed care. I think that it'll be a good, but that's where we're moving. It's moving away from the counties and the state and to the health plans for Medi-Cal.
Other questions? Oh, hang on. There's a mic coming for you. Just for the people who are virtual.
Jerry Rogan, retired family doctor. Could you tell us about the cost of medical malpractice insurance for a family nurse practitioner, for a
Midwife?
nurse midwife compared to an obstetrician?
Yeah, so that's a tricky thing. A lot of malpractice companies won't cover midwives who are outside of a group. The majority of nurse midwives practice in hospitals as part of that these days. Most community birth midwives do not. And so those in solo practice and those in community birth are the ones who have to buy their own malpractice insurance, which is quite difficult because most malpractice insurance companies only cater to physicians and to those who are within a group. The cost is similar though, and it can be quite prohibitive given that in community birth settings, meaning at the hospital, out of hospital, so home birth and freestanding birth center birth, the volume is low and the reimbursement is less. And so you're seeing fewer patients, you're having fewer opportunities to make money, and because the facility fee is different or absent for a home birth, there isn't any reimbursement there. While malpractice insurance costs, are quite comparable to what they are for a physician or to a nurse midwife who's working in a hospital setting with a large volume, as I have, right? And that has a regular facility fee because it's a hospital. So that's one of the barriers that you bring up, actually. Thank you for sharing that.
And just to tag on that, because I as a family doc, I delivered babies for 13 years, and the first 5 babies every month were paying for my liability insurance. So you have to have a high volume. If you end up with a low volume, you're doing it for the goodness of your heart. So.
Yes, for your passion. And hopefully your partner is wealthy.
Any other questions from the audience? If not, I'll end on a thought experiment, rapid fire for each of you. If you lived in Madera County right now, we'll pick on them just because they've been in the news. I think a lot of people are familiar with the situation and the hospital closure there. If you lived there and you were giving birth right now, or a loved one was giving birth, what would your plan be?
Since I know how to do, I'd probably, if it were, assuming maybe it's my daughter or something.
Yeah,
right?
wait a
Separate
minute.
yourself.
But no, so this is not a unfounded question. So what you need to do is have somebody who knows how to deliver a baby, who lives in that rural area, because not all of them are going to wait for transport. That's a really important thing. So you need to have someone with core skills, and then a little trunk. We have birth kits that you can put in your trunk. You probably have one. So that's in rural areas, and I know there's someone from the EMS. In the rural areas, EMS, CHP, or a nurse that happens to live in the community, they all need to be ready to be called into action on a very occasional basis to help out. So.
You have thoughts on like keeping up the skills for that kind of population?
Yeah, I think that's part of our model is the places that have lost it. The key there is a ton of training to give people the skills for the doctors and the nurses and the paramedics and anyone who might be doing that to have enough skills to be able to handle what might come their way. So, and that needs to be sustained over time.
So you might not guess this about me, but I'm a planner, so I would have a plan written out that I would have given to 15 of my very closest friends. This is what you do in the case of an emergency birth. But I would, if my plan were to go awry, I would feel very comfortable with doula support throughout. So hopefully I would have made extended a relationship with a doula, and I'd be very comfortable calling my doula to help me with the next step.
That's what I was gonna say, because I've actually spoken to birthing people in Madera, Fresno, and those areas, and yeah, have a well thought out plan, as thought out as you can, because things change. Make sure that you have a good support system. Find out alternatives. Hospitals make a plan to get there as soon as possible, and just have folks on speed dial.
I'd call a midwife. I would probably find out if there were any midwives in my community who offered community birth, since there's not a hospital there to offer birth. Of course, this would be assuming that I was comfortable with the idea of giving birth without an epidural or IV drugs. But if I was, then I would find out if there was a midwife in my community who attended birth. I would find out what her backup, her plan B was. Their plan B, might not be a her. Because we need to be within a reasonable distance of a hospital, find out how that works. I would probably try to find somebody that was like right between me and the hospital, so that I could halfway that and make the drive reasonable. And I would probably also find out who my friends were that had birth skills, my lactation friends, my my family doctor. I love my family doctor. She does not attend birth though. But I would find those who had those skills and newborn skills, specifically maybe newborn nurses, nurse practitioners who are in the community where I lived, who might be able to come and help me in the early days afterwards if the clinic is not providing all of the care that I'm going to need. Not just for the regular visits, but for support. Who's my lactation friend that's going to help me with nursing and help this latch and make sure the baby's getting enough milk? Who's got a newborn weighing scale that can help me, not just for the 2-week and then the 2-month visit, but in the interim period? Because there's a lot that goes on that's not just getting the baby out.
Well, and you asked the question as a thought experiment, but I want to bring us back into the reality that many birthing people are having this conversation today. And are making those kinds of plans because they're not sure if they will be able to get to the next nearest hospital that can help them with the birth. So,
Well, thank you so much for being here, all of you. Obviously, we could talk about this for a lot longer, but I will let Neil close us out.
Kristen, thank you, and thanks to you all. You said it so well at the end. This is not a thought experiment, right? This is a conversation about something. Kristen, kudos to you for taking us through the problems and the solutions, and all of you for bringing that. This is something we have to talk about right now, and I'm glad we got to go through it. Kristen did a lot of work on these stories, along with her colleague Ana Ibarra, who's based down in Southern California for us, and Erica Yee, who's in the back of the room hiding, who did a lot of the data analysis work on this. Thanks to you all for this, and everybody else on the team here who's done this. We can't do this work without the support of you, the folks who donate to us. We are a nonprofit. This particular session is made possible by California Wellness Foundation and the California Healthcare Foundation, which support our healthcare journalism. Very grateful to them. Very grateful to everybody for helping out. Nice to see that Kristen has learned not to use the word alternative in any story relating to midwives in the future. You won't see that anymore. And I want to thank everybody for coming and hope to see you again soon. Thank you.